I believe, since every medicine person is also a tiny bit neurologist. And I'm not gonna like shovel too much into the details, but all these things are things that even if you've forgotten the neuroanatomy, these are things we'll start from, oh, you know, the brain has gray matter and white matter, and we're fine with that, okay? All right. Okay, this is kind of the flow of what we're gonna do today. Just basics, what basal ganglia is, the infamous circuits that happen within the basal ganglia, what do they really do, and tilting it towards how can we really apply it when we see Parkinson's. And before we go ahead, I have a little riddle for everyone. Can everyone just focus on the last one, on the 7th here, and we'll come to the answer at the end of it. So there's a beginner level and there's an advanced level. Beginner level, just diagnose what's the disease. Advanced level, there are 7 hints to that disease hidden within this one riddle. Caged in your own body, aggression, depression, all at once. The striatum is sick, the inhibitions too weak, the dance too deadly, the dad, the death bringer, the descent too dominant. And we'll come back to it at the end. Okay, all we know is gray matter and white matter, nothing else. We don't need anything else. The brain outside is the gray matter, which just means collection of cell bodies, and outside has to be white matter because if it wasn't, it would all be gray matter. But there is something which is not white matter inside of that gray matter, which is another layer of gray matter, and that essentially is basal ganglia, which is a misnomer because since it is the central nervous system, they should be called nuclei because it's near the base of the brain, basal, nuclei because they're gray matter, and deep because they're deep within the brain. That's all we need to know. So there can be different structures within the brain, like you see, which aren't white matter but embedded in white matter. All of it is basal ganglia. But some of them are like more intricately related to each other. And like all we know and wherever we stop is, oh, they have something to do with movements. That's it. But then your primary motor cortex is what helps you initiate movements. What does basal ganglia do? Oh, but your premotor cortex is what helps you decide what movement has to happen. But then what does basal ganglia do? So it basically works something like this. Your premotor cortex is where you think that you need to move this elbow or do a certain movement. Then the signals go deep down in your brain where the magic happens with basal ganglia, and the signal comes back to the primary motor cortex. Just think of your primary motor cortex as the fingers of the puppeteer. If you stimulate that area, the homunculus is going to move that leg or the arm, nothing else. What we're going to talk about in simple is what magic happens in those basal ganglia, right? So a lot of things I don't want you to remember. That's absolutely okay. What I want you to take away from this session is feeling that, oh, that makes sense and that's easy to understand. So here's the cortex, right? And here's the thalamus. At all times, your thalamus is trying to send impulses to your cortex to do the movements. But are you moving at baseline? Not really. Because something is inhibiting that thalamus, right? At any time you think, oh, I gotta move this arm. So your biceps flex, but something also happens simultaneously. Your triceps are inhibited. That is what's gonna cause a functional movement. So 2 parallel circuits happen at both times, at simultaneous times. What happens is there's a direct pathway. So from your cortex, premotor cortex, impulses go to the striatum, they go to the globus pallidus internus, they go to the thalamus, and they cause the disinhibition, which is release of that inhibition from thalamus, which causes your movements to happen. The indirect pathway is increase in intensity of that inhibition. So certain movements need to be inhibited. And all of these intricacies, they are like too complex for your mind to consciously think. That is the reason they all happen on a subconscious level within your basal ganglia. And your primary motor cortex just like reacts to what is coming from the basal ganglia. It's absolutely okay if you guys are not interested in neurology too much. We don't have to know the details, but just know cortex is the final thing that will make things happen, and magic is happening through the basal ganglia, which is important to know, and we can skip all of this. But one thing that I want you to know, I talked about the direct and the indirect pathway. Where does dopamine or Parkinson's or substantia nigra even play a role? This is the most important thing that you need to remember at the end of it all. That's it. So your direct pathway is what causes an action to be taken. I don't like to call it stimulatory or inhibitory because both pathways involve both neurotransmitters. Just think of it, direct causes movement, indirect inhibits the movement. That's it. These are very intricate things that happen within the brain, but they are not just enough to cause movements of such large motions. So these cycles need to be amplified. The amplifier is the dopamine, which comes from your substantia nigra. So it's like the sidekick, side superstar. People do call it the modifier, but I like to call it the amplifier because it's not changing anything. It's just amplifying those circles, making that happen much, much more. So there's one question that I have for everyone from the back of your head. Do you remember which pathway is affected in Parkinson's? Anyone who says direct pathway, you can think of this as symptoms like, or the indirect pathway. Or we don't know. That's fair enough. Because it was a trick question, right? Substantia nigra, forget everything. Parkinson's, we give, all we know as medicine people is we give L-dopa, dopamine. That means Parkinson's has less dopamine. The fact is, if I am a structure within the brain, I want to stimulate something or inhibit something. I can make glutamate to stimulate or I can make GABA to inhibit. But I'm a lazy brain structure. I'm like, I can only make dopamine. You want to get stimulated or you want to get inhibited. You decide what receptors you want to make. I'm just going to send you dopamine, right? So the direct pathway just builds in D1 receptors because I want to get stimulated. I'll take your dopamine and get stimulated. And the indirect pathway just builds D2 receptors. And then when it gets the same dopamine, it gets inhibited. Cool idea, right? Brain's super fun, super amazing, efficient. Something happens terrible because of this shortcut that our brain takes. If you had two different neurotransmitters, it would be very rare for both of them to simultaneously get affected. But if something happens to your dopamine, both these things get affected because it's the same dopamine molecule, right? And then we come down to, okay, everyone already knows this. 3 things that you need to remember when you see Parkinson's. Oh, what is it? Bradykinesia? Oh, yes. Oh, tremors? Okay, yes. And cogwheel rigidity. But I like to think all we know is the pathophysiology. Let's try and make sense of why everything's happening. Because the same dopamine is less, direct pathway is not functioning, you cannot initiate movements. There is bradykinesia. The same dopamine is also less in the indirect pathway, the movements cannot be stopped. So there's tremors. And at the same time, both pathways aren't in balance, so cannot stimulate, cannot inhibit, there's cogwheel rigidity. So one problem causing all of it, right? And one thing that I want you to remember at the same time is, we think, yes, oh, Parkinson's, throw them to the neurologists. Sure, we have neurologists, but don't be afraid to think on lines that I'm pretty confident this is looking to me like a Parkinsonian picture. It is a clinical diagnosis. You can then get done all the tests and imaging done, but it will still stay a clinical diagnosis. And there are things that can help you support it, and they're very commonsensical things. Besides the features, if there's an absence of alternative diagnosis, that supports Parkinson's. If there's a response to levodopa, that highly supports Parkinson's. And I don't think like you really need a crazy genius person for you to think in that direction. Another bias that a lot of people have is using the terms Parkinsonism and Parkinson's disease interchangeably. Like I said, since it's a clinical diagnosis, you're seeing the symptoms, I see these symptoms, it fits into the Parkinsonian bucket. I should feel comfortable, you are a case of Parkinsonism, which necessarily does not need to mean that I also know why you have Parkinsonism. One cause of Parkinsonism is Parkinson's disease, which is basically idiopathic Parkinson's, right? And that is basically associated with the loss of substantia nigra in your brain and hence less dopamine. But there can be so many other things. Firstly, rule out the secondary causes. There always has to be a balance between dopamine and acetylcholine in your head. If dopamine is less for whatever reason, like in Parkinson's disease, you will have symptoms. But if for whatever reason your acetylcholine is more, there is still a relative deficiency of dopamine. So that is what causes drug-induced Parkinson's, right? That is as much Parkinsonism. So you want to first think on things like cholinergic medications, anticholinergics causing those symptoms as well. But then there is a category of primary Parkinson's, which is basically, yes, most commonly Parkinson's disease, but I will agree, we don't know why there are so many degenerative changes in different parts of the brain. And there can be changes in parts of the brain which can lead to those symptoms, but that wasn't just due to the degeneration of substantia nigra. So yes, we start by diagnosing it as something Parkinson's, but there's also other symptoms. So Parkinson plus syndrome. The only thing that gets them together are two things. They do have Parkinsonian features, and they have their own unique features. I don't want to go into the details, that's too much neurology. But what you want to know is, I thought it's Parkinson's. The first thought that should come in my head is, probably idiopathic Parkinson's because that's most common. What do? Start levodopa. He should respond. He's not. Then think about Parkinson plus syndromes. The common thing that connects Parkinson plus syndromes is lack of response to levodopa, right? So you don't have to straight away think in that direction. I just talked about that. One of the Parkinson plus syndromes is Lewy body dementia. So in Parkinson's, you'll have movement symptoms and at some stage later also cognitive decline. In Lewy body dementia, it's very similar. It's just the timing of Lewy body dementia happening at the same time or even before the movement dysfunctions, and you find the same pathological findings. No need to go into the details of the drugs, you already know. One thing that I like to reiterate is just knowing the pathophysiology helps you think on lines of what drugs you need to avoid. You know, L-DOPA, you need dopamine in your body, so at least don't give anti-dopaminergic drugs. And that is when things come of use from your knowledge, like, you know, metoclopramide is anti-dopaminergic, antipsychotics work on that function, and quetiapine is one of the least anti-dopaminergic antipsychotics, so that's possible, a possible option. One thing I feel, this is almost my last slide, but I feel is a lot of people get confused with is the on-off phenomenon of Parkinson's due to levodopa and carbidopa. What is the on-off phenomenon? So I diagnose someone with Parkinson's disease, and then he gets started on levodopa, carbidopa. Your body still did have some reserve of dopamine. Now you started giving L-DOPA, your body feels that there's enough dopamine coming from the outside. I start depleting my reserves. But there's one difference between the dopamine within your body and the one that comes from outside. Your body has a continuous supply of that dopamine. So there's always a homeostasis. But when you are giving the L-DOPA, which already has a very short half-life of 90 minutes, you cannot give a medication essentially every 90 minutes. Over time, you see, the blood level stays, the blood trough stays the same. What actually changes is, because your endogenous dopamine is decreasing, the time during which that L-DOPA remains therapeutic, that window starts shortening. And whenever you're above that range is when you have the on symptoms. That is, there's too much L-DOPA causing dopaminergic side effects like dyskinesias. And whenever it starts wearing off, you have the off symptoms, which is too less dopamine, and hence very classically freezing of movement. So one thing you want to take away from here is, if hypothetically you find a person you want to diagnose as Parkinson's at an earlier age, think of things that you can prevent or at least delay starting him on dopaminergic medications and L-DOPA. So that is when the other medications are much more use. Just to wrap up the session, these are the Nissel's granules or clinical pearls that is okay that you can take away from here and forget everything else. No, Parkinsonism is different from Parkinson's disease. Don't anchor. Parkinson's is a clinical diagnosis, so definitely call your neuro colleagues and have a conversation with them. You know enough. On-off phenomenon, so please avoid starting it early in a young person. Use the medications which do not affect the dopaminergic pathway. Parkinson plus syndromes that, like I talked about, Lewy body versus Parkinson's, and there's a newer therapy in town called deep brain stimulation, which is obviously being used for some time now. The reflex response that people have is, oh, probably it stimulates the brain and helps them either produce dopamine or do things. Actually, DBS specifically gives in high frequency vibrations, and deep brain stimulation inhibits neuronal pathways. And those neuronal pathways are basically the one in subthalamus and globus pallidus internus, technically the parts that I skipped over, which inhibit the thalamus. So if you inhibit something that is inhibiting the activity, you actually cause stimulation. That is how deep brain stimulation works. We know an ocean about neurons and not even a drop when billions of them come together to emerge as brains. It's what we allow to overpower us, fascination or fear. That decides whether the tiny neurologist in each one of us lives or dies. So please choose to be fascinated. Thank you. And this is just the answer if you guys wanted to think about the answer to the riddle that we shared. If anyone has any guesses. Sorry?
Oh, we saw it.
Okay, I mean, you can see and tell the answer, it's fine. So just to stay on the theme of neuromuscular disorders, it was Huntington's chorea and Huntington's disease. I'm sure like most of us did get it, but just like how I created this riddle was like there are like 7 hints hidden in there. So if you see the first word, caged, CAG is the trinucleotide repeat that happens aggression and depression because acute onset psychosis. The striatum is what is affected, which is the caudate and the putamen. The inhibition's too weak because the extrapyramidal inhibitory pathway is compromised. The dance, basically chorea, too deadly. The dad, because paternal genetic anticipation is what causes Huntington's chorea. So if you get the same disease from your father, the next generation is going to be much more severe versus if you get the genetic mutation from your mother, right? So that is the dad, the death bringer, and the descent to dominant, autosomal dominant inheritance. So thank you for your time.